Well, hello. AI in healthcare is full of promises, and few people can tell you how to keep them. Today, a leader from a company at the very forefront of the AI boom is here to show us what responsible, human centered AI actually looks like in practice. And that company is none other than Microsoft. Welcome back to Humanify Health Tech, where we explore how AI is rewriting the rules of healthcare and putting people right at the center where they belong. I'm your host, Francesca Vereb, Head of Marketing at NetHealth. And today we are thrilled to welcome Dr. David Rhew, Microsoft's Global Chief Medical Officer and Vice President of Healthcare. Now, Dr. Rhew is leading some of the most important work happening at the intersection of medicine and technology, specifically how we responsibly bring AI into patient care. He's a physician, technologist, and inventor with 6 US patents, and he shared his insights everywhere from the HIMSS Global Health Conference to the Vatican. We're especially excited to have him here today because he'll be our opening keynote speaker at NetHealth's Next 2026 in April, where he'll be talking about AI for better health and how human-centered AI is transforming specialty care. Dr. Rhew, welcome to the podcast.
Thank you, Francesca. I'm excited to be here.
That is so good. I couldn't be more excited to have you. As I mentioned, you've worn many hats: infectious disease physician, researcher, and tech executive. So when you're advising healthcare systems on AI integration today, what patient moments from your clinical days still shape how you think about implementing technology?
Yes, great question. Throughout my career, I have oftentimes been very excited over technology. But at times, I've also been frustrated with the technology. And I think the key lesson for me as a clinician and as a researcher has been to really appreciate the clinical workflows. If we're trying to enable improved care, you need to have individuals using the technology. There's no value in having technology sit on the shelf, and understanding those workflows is essential. And oftentimes we think that sometimes the technology will solve one problem, but it's really the workflows that enable this. So let me give you an example. Early in my career, I was fascinated by the fact that we had so much variation in care. And I was curious why there was so much variation. A lot of it was actually unwarranted. And I started thinking about, is there a way that we could actually improve the standardization of care, or specifically around what we'll call evidence-based practices? And so I built this product. It was called an evidence-based order set. And ultimately, this is a product that we found a way to integrate into the electronic health record. And this was something that was being launched throughout the United States, specifically as electronic health records were starting to become more popular. And as a researcher, I was extremely excited because the evidence-based order sets were shown to not only reduce the variation, but also decrease mortality and improve overall efficiency. So there was a lot of benefits from using these. Well, what turns out is that it was widely adopted not because of the clinical benefits, but it was adopted because it saved the clinicians 95% of the time required to enter orders into the electronic health record. And so appreciating that allowed us to be able to then get to the point where we had widespread adoption. And ultimately, then we saw improved quality of care. So a lot of times we think that it's actually the quality of care that's going to drive the behavior change or the improved safety, but it was the improved clinical workflows. And I think for me, that was the one thing that has continued to stick with me. How do we ensure that no matter what we put in front of clinicians, that it actually is workflow compatible?
It's so interesting you mentioned that, because one of the things that we keep touching on is this notion of the myth of AI reality versus the true reality of what it's delivering. And the fact that you're talking about workflows and saving time is such an interesting point, because you've seen these medical AI scribes deployed across hundreds of healthcare organizations and settings through the partnerships with Microsoft. And, here specifically at NetHealth, we're hearing everything from, as you've just mentioned, it saves me 2 hours in pajama time a day, to it creates, more work fixing those errors, right? So there's a little bit of a dichotomy there as well. So what separates successful ambient AI implementations from those disasters?
Yeah, so I think the first thing that we all need to recognize is that the AI continues to get better. And so the earlier evaluations of scribes and a lot of the technologies that we saw first deployed have gotten to the point where a lot of those issues that we've seen in the past are no longer present. So staying on top of things is probably maybe the first thing that's important. But also the thing that is really important is to understand who is using it. Now, there are some clinicians that they're not necessarily super busy or burdened with the task of note writing, or maybe their notes are pretty simple and it's just for them, it's a very straightforward task. There's probably not a huge amount of benefit from ambient in those scenarios. But if you have somebody who is working in a very busy practice, they're spending a lot of time writing notes, they're burned out, they're frustrated, then in that scenario, ambient may be actually extremely valuable. And so I think understanding who we're seeing, and this also plays out because we see a mixture in all practices and settings. And sometimes it turns out that individuals that have marginal benefit are being, their impact is being measured with those that have significant. And so I think it's really important to start recognizing that the importance is not on average, did it improve things? But if you talk about the individual physicians and how many of them actually feel like their lives have gotten better and that the burnout has decreased and their satisfaction has improved, and also the patients, if their satisfaction has improved. And those metrics are extremely impactful because we're starting to see with the newer AI ambient technologies that we're finding ways that we can actually reduce the burnout. And honestly, by reducing the burnout, it's such an important issue because without clinicians, we really don't have healthcare. And so we have to think about ways to be able to address this. And ambient has become an extremely valuable tool.
I think it's such a spot on point. I mean, at the core of healthcare is really trust, right? You're talking about how the clinicians themselves trust the technology enough to use it. You're talking about certain workflows and some of that trust linkage there as well. And you actually helped launch Train, which really stands for Trustworthy and Responsible AI Network. And you did so with, was it about 16 or more healthcare systems, specifically to operationalize responsible AI principles. If I talk about from a net health perspective, we've recently introduced some comprehensive data and AI governance plans that really emphasize things like GDPR, HIPAA, and ONC DSI certification. But when you talk about that and the linkage between people using technology, right, and that compliance and that sort of adoption of it, what are the non-negotiable elements of an AI governance framework when you think about trust underpinning that?
Yeah. So the Trustworthy Responsible AI Network was launched in response to the fact that many organizations were saying, hey, we think responsible AI is important, but how can we do this in an efficient manner? How do we do this with limited resources? Because there's just too much AI. So that was launched over a year and a half ago. And right now we have over 70 health systems, maybe close to 80 across 2 continents. So it's really expanded, and largely because of the fact that we're all recognize the importance of this. And to the point of what are the non-negotiable elements? I mean, let's start with just the basics in terms of privacy, security, regulatory compliance. Those are absolutely non-negotiable. We have to make sure that those are in place. But on top of that, we're starting to recognize that other non-negotiable pieces are, we really do have to manage the AI. We cannot just simply let it, it's run in our systems and just hope that it provides good, better care. So in order to do that, we have to ask 5 basic questions. Do we know what type of AI is running in our system today? So that's the first question. The second is, have we tested the AI on local data sets or data sets that are diverse and ultimately representative of your population? And a corollary to that is, have you monitored them post-deployment? And then we have to ask the question, have we looked for bias? And bias in the models, and bias in how it's being deployed, bias in terms of impact in subpopulations. So we need to think about that as well. We need to start thinking about how have we developed a process for governing all of this. And ultimately, the governance process is extremely important, but it also is time consuming. And we have to think about how to do this all in a time and resource and cost efficient manner. So these are the types of things that we have to ask ourselves. If we don't answer those questions in an affirmative, then what we're doing is we are creating gaps of potential opportunities where the AI may drift, may do things that are kind of unexpected, and we ultimately will find that it doesn't deliver on the value.
You brought up two great points. One, I want to come back and talk about bias in a second, but you also touched on the fact that you've expanded this over global sort of healthcare environments. You also spoke a little bit about different sort of community care, and I think you touched on the even sort of the rural concept, right? So Train specifically collaborates with Ocean and TrueBridge to ensure that organizations, regardless of their resources, can access AI benefits and avoid perpetuating that bias. But many of NetHealth's environments as well, we serve many clients in the rural and sort of community-based populations. But as we think about AI adoption accelerating, as you touched on a second ago, what are those biggest threats to healthcare equity? And what guardrails do we need to make sure we put in place to ensure innovation reduces but doesn't reinforce some of those disparities? And then we'll expand on bias in a second.
Yeah, that's a great question. And, obviously technology can do a lot. A lot of positive things can be derived from technology, but it can't if you don't have the basic infrastructure to run it. We're talking about things like access to broadband, cloud infrastructure, cyber protections, the resources to be able to manage this. And so to help with that, Microsoft, even well before AI was sort of being talked about on a regular basis, we had recognized that just digital technology infrastructure is essential. And we wanted to ensure that organizations and individuals across the globe had access to affordable broadband. We launched an initiative called Airband, which allowed us to be able to expand the capabilities, and largely by working in collaboration through public-private partnerships to be able to offer discounted rates of these technologies for individuals across different areas. And we've seen millions of individuals now have access to affordable broadband. And more recently, with specifically emphasis on rural health, we launched something called the Rural Health Resiliency Program. And so as part of that, we were specifically looking at ways that we can enable rural hospitals to be able to get access to the cloud infrastructure that is necessary for running AI, and then the cyber protections that are necessary to secure the data on the cloud, and then also to enable the discounts that we see. So you can't just simply provide these technologies at regular prices. You have to actually enable this to be done at an affordable process. And so that was something that we felt was extremely valuable as building on it. And then, of course, we just talked about this recently, the Trustworthy Responsible AI Network, helping organizations work together to share in their ability to learn from each other and ultimately be able to do things in a time and cost and resource efficient manner. That's allowing us to be able to think of new models of care where we potentially can enable what we call a hub and spoke model, where higher resourced organizations can provide some of the infrastructure and support that supports lower resourced ones. And these are the types of strategies and technologies and approaches that are going to allow us to be able to democratize healthcare technologies across all regions, not just in the US, but also globally.
I absolutely love that whole idea. And I think that's so important, especially here on our podcast, where our theme is really about, how technology is so human centric. I want to stay on that thread of trust just for one, second more and really start to sort of dig a little bit into some of the bias. So your keynote that you're doing for us in April really emphasizes the notion of rebuilding trust in healthcare systems. And particularly at a time where healthcare misinformation is starting to be weaponized a little bit. We're hearing a lot of that in the news. And this trust in healthcare organizations seems to be declining. In fact, there was a recent stat with the Civic Health and Institutes project that found that general confidence in doctors and hospitals dropped from 70% in 2020 to 40% in 2025, which is alarming. Now, NetHealth's governance, our framework really tries to address this better, but our clients often tell us that their clinicians are skeptical of another tech solution, quote unquote. So how do you counsel health systems as they rebuild this clinician's trust when they're thinking about AI tools that are being layered on top of EHRs that they're already a little bit frustrated about?
Yeah, you know what? Trust is essential at multiple different levels. There's trust with the clinician, which is what we're talking about here. And how do you build trust? Well, they have to be involved. They have to understand what, the data are that behind it, the transparency of the models. They have to understand how it's going to impact their lives. You have to understand whether or not the AI will actually continue to stay effective in terms of its overall deployments. And I feel like these are the types of things that healthcare physicians and organizations need to think about. But then there's another level of trust, which is around patients. and patients and consumers trusting the technology. And I think that is something that we also have started to realize the importance of. You can't just simply run it on the provider side and expect patients to be able to believe that this is going to be leading to things. There are issues that relate to one, do I really understand when this is being used? So like the first question is, have you told me about this? Like just the general awareness. We've also recognized that consumers are concerned about, like with the data that's being captured, what's going to be done with it? Is it going to be somehow exposed to folks that I'm not particularly interested in having this exposed to? So this whole concept of data management and governance is essential. And so that then ties back into the transparency. And then giving individuals the opportunity to opt in and opt out. I think that with an informed decision, they might be able to do that. Now, many physicians or many patients will likely say, well, I trust you and I trust your decision making to do the right thing for me. But just like with anything, we do need informed consent, and we do need to make sure people know what's going on so that they can actually feel confident and trust in it.
I agree with you on that. And you know, you specifically hold 6 US patents on clinical decision support and EHR data interoperability. You actually recently joined Ignite Data's board specifically because AI and interoperability makes that process so much more efficient, inclusive, and accessible. So how does poor data interoperability really limit what's possible with clinical AI? And what should specialty EHR specifically be doing differently in this scenario?
Yeah, I'm glad you mentioned that question because I oftentimes find that people talk about AI, data, and interoperability as 3 separate entities. Well, in reality, they're interrelated. And what we find is that the AI is highly dependent on the data sets that they were built off of, that they were modeled after. And those data sets really do need to be large, diverse, and oftentimes we don't see that because it's hard to be able to get access to these large, diverse data sets. So what ends up happening is it's tested on smaller data sets that may not be representative of larger populations. But at the same time, we want to generalize the AI on larger populations. So this whole interrelationship between AI and the data sets is important. Now, how do you create large data sets and make sure that we're actually able to pull in different data sets from different systems? Well, of course, we've got regulatory privacy rules and things of that prevented. So we do need to think about how we can enable different mechanisms to be able to pool data sets, whether it's centrally or through a decentralized process like federated learning. But interoperability is essential because if we have these data sets in different areas and we want to pool them, it can only happen if the data sets are all speaking the same language. And that is interoperability. That's why it actually is both the AI, the data, and the interoperability that need to be done in collaboration and coordination. And we're starting to see improvements in all 3 areas, which is why we're starting to see so much great opportunities for AI. Now, what should EHRs be doing? Well, obviously, in order for us to be able to think about how to improve that interoperability piece, it would be very beneficial if we could actually enable not only access to these pieces of information, but complete access. There's like, when an individual, if a consumer says, I want my medical record, we don't want just sort of like the minimal requirements, the minimal downloads. We want actually the full comprehensive data sets, including notes and things like that. And largely because it's up to the consumer to decide where those notes should be sent to. If it's another clinician or if it's going to be done through an AI model, that is something that the consumer should be able to gain complete access to and real-time access to. And this is a challenge that goes beyond the EHR because how can you ensure that we're getting real-time access as opposed to delays which occur or piecemeal information coming here and there? And I think this is something that we're going to continue to see more of, an opportunity for us to think about how different systems work together to be able to enable consumers to be able to get complete and real-time access to their data sets so they can better manage it or transfer them to the individuals that can.
So I heard you say large sample sizes, the types of access, the broad ability to access different types of data, timing is a key thing. But isn't it also true that there is sometimes some inherent bias in some of those data sets? And Dr. Geeta Nayar, who's actually a friend of the show and occasional co-host here, she really goes into, in her book, she talks a lot about misinformation. And she talks about how we have to combat that and make sure that it's equitable, racially sensitive, right? As we're thinking about how we're potentially finding AI perpetuating some of the disparities and maybe even victimizing some of the more underserved populations, right? And then researchers at Mount Sinai found that LLMs often just repeat and then even expand on some of this false medical information and do it so convincingly, like they, with a lot of confidence, make it sound so real. So, what does clinical grade AI really need to include in order to ensure it's acting, that it's actually reducing misinformation rather than just creating it with this veneer of authority?
Yeah, I mean, you've touched on so many important topics within that question. The first is the difference between with bias, looking at bias in terms of what we see in AI. Some of it is not intentional bias. Actually, a large part of it is not. It's just simply the fact that we had a very narrow data set that we have determined the AI model. And now what we're doing is we're applying it to other, individuals and other populations. And so in that application of that very narrow model to more generalized settings, we have found that it doesn't work as well. And then in that process, it has created disparities in terms of outcomes, specifically in groups that are not well represented in those data sets. And who's not well represented? Turns out that it's the vulnerable, it's the low resource, it's the underserved, because they haven't been able to gain access to the health system. The data hasn't been, they don't come in regularly, they don't get all the tests. And so because of that, that sort of influences the data sets to become much more reflective of a different type of population. So to me, that's like one element that we have to start thinking about. Now, the other is about misinformation and propagation of misinformation. Now, that can be done largely because of the fact that people don't know what the truths are and they don't believe the truths. And so there's a whole element here of how do we change the whole concept of like, what is truth? And I think it largely stems from the fact that we're not all on the same page in terms of what is ground truth. Some people believe that ground truth is the last thing that I saw. If somebody said that I had an experience and this is what, maybe there was a side effect with a medication. Now we think all medications are bad, or all treatments are bad. Well, is that evidence? Or that's one piece of evidence, but now if we're applying it for a general population, is it true that all the medicines are bad for every single person? Now, some people have allergies. Some people have unique reasons why they have adverse reactions to different things. What we have found is that randomized controlled trials, allow us to be able to study things in a way that allows us to be able to understand whether or not certain treatments are better or worse on a larger population, not necessarily an individual population, but a larger population. And in those scenarios, if we're going to make a generalization about whether treatment is good for a population, those type of studies actually should carry more weight. Now, where are we heading? We're actually now heading towards more personalized medicines. And so we may be able to start learning from individual experiences just like you on what your best treatment is. And that may end up becoming the best option, but we're not quite there yet. And so that's why it's important to know where we're at right now. We are at the point where we're gathering large sources of data. We're starting to better analyze it. And I think the education is not just on the clinician side, but it's going to have to be on the consumer side. Imagine this, our because of cuts to education, because of the lack of focus on a lot of this, people are not only not learning all the science that's necessary, but they're not learning what I could refer to as the scientific method. If more and more people were introduced to this concept of two pieces of information, which is the one that is more likely to be true for under general population, I think we would probably start getting people to better understand that. And then the last thing is, where are you getting your information source from? Are you getting it from we'll call it a trusted individual that has an understanding of it, or are you just getting it from a trusted individual? And I think with nowadays, trusted individuals can come in all shapes and sizes. Some may have some scientific understanding, some may have none. And I think what we're finding is that people are relying on just the fact that I've worked with this person, I listen to them, I trust them, as opposed to that plus this person understands the scientific method. So I think there's a lot here to unpack. This is obviously a very important topic, but one that I think that we collectively as a society need to address.
I feel like you've seen into my soul because with my recent doctor's office, I took my notes that I got and put them into, Claude and got an assessment. And I think that a lot of healthcare workers, you spoke about consumers here, you spoke about, who is that trusted individual? Is your trusted individual your AI, model that's helping you? And I think these healthcare workers are grappling with this notion of shadow AI, right? Like staff, I think, are using unapproved AI tools themselves because they're using, transcription notes or different ways to sort of combat their own burnout and staffing shortages. And that's forcing organizations to have to think about how to implement formal governance frameworks around those. And then you've got patients who are also running doctor's notes through your ChatGPTs, your Claudes, your Geminis, etc., without any clinical context, as you just described. So when you've got patients self-diagnosing using AI or clinicians using unauthorized AI tools, who's accountable when something goes wrong? In other words, how do we do what you just said, which is balance that innovation with patient safety when the technology is moving a lot faster than our governance structures, right? How do we do that?
Yes. And we are at that point right now where the technologies are getting so good that people are relying on them for medical advice, independent of clinicians. And I think that's not necessarily the path that we should be looking at right now or encouraging, because of the fact that there are some things that the AI can do very well, and then some things that the AI with the doctors and clinicians will allow us to be able to do better. So if I look across the board, let me just kind of reflect back on the days that I was a clinician. When a patient came to see me and I gave them a recommendation in terms of what the treatment was, prescribe a medication, certain amount of exercise, diet, and ultimately making sure that to know what are the warning signs. These are the types of things that I would give at a very general level. Now, as a patient, I would gather that information, or an individual would, and they may have a lot of questions. And yet I didn't have enough time to talk to the doctor about it. I didn't understand, you said take it 3 times a day. Am I supposed to take it every 8 hours, or am I supposed to take it 3 times a day during the daytime? Breakfast, lunch, and dinner. You told me that I need to eat this with food, any type of food. Like what about the spicy foods? You name it. There's a lot of questions that come up. People also have questions. You told me to exercise. How much should I exercise? You told me to eat right, low sodium. What's low sodium? Is this food low sodium? All those questions about how you would translate what the doctor was saying into real life, AI can do very well. Similarly, if I were to see the doctor preparing for my surgery and I want to ask questions about what questions should I be asking when I see the doctor, AI can help us prepare for that. AI helps fill in the void for so many of the things that we currently do not have resources for, but it is also done best in collaboration and coordination with a healthcare provider, so that whatever we're doing is supportive as opposed to replacing. And we oftentimes know that AI has not yet been tested in some of those independent manners. So for us to be able to start relying on things for everything would be an overshoot. But if we rely on AI to help us with things that have never been addressed before and really give us guidance, but ultimately deferring back to the clinicians for final input, I think that allows us to be able to balance the issue of answering questions, but also doing it in a safe and effective manner.
That sounds fantastic. And such great counsel and guidance there. Let's switch gears a little bit. Let's think about what we're hearing and seeing a lot in the news of late. There's a lot of discussion about all these great AI pilots, and there's a lot of discussion about how do we actually get these into production. So, the proverbial sort of implementation gap. And many of these healthcare organizations are getting stuck in this perpetual sort of pilot mode, right, with AI. And you've actually distinguished between the Coalition for Health AI, CHAI, which is about defining what responsible AI is, and then train, which we spoke about earlier, which is really focused on figuring out how to implement it. So what advice would you give for moving from proof of concept to scaled AI deployment? And what should organizations make sure they change in order to be able to support that happening?
Yeah. So I'm going to reflect on one of my experiences. Before I joined Microsoft, I was chief medical officer at Samsung, and we worked with Kaiser Permanente on an initiative called home-based cardiac rehab. So let me start with the problem. The problem was that a lot of individuals, after they'd have a heart attack or have some type of cardiac surgery, needed this cardiac rehab program. Why? Because it turns out that program saves lives. and it prevents hospitalizations. And it's something that's very valuable. Okay, why are they not doing it? It turns out because it's very difficult. It's a 6-week program. Every week you have to come in 3 times a week. You have to exercise for 30 minutes, and you basically have to commit to doing this. Well, people have jobs. They are busy taking care of their kids. They live far away. And to be able to do this on such a regular basis is a huge commitment, that most individuals can't do. So at KP, their baseline rate prior to the implementation of this home-based program was around 40%, which is really not good. Less than half of the people are receiving this life-saving treatment. So what we decided was to ask the cardiologist, does the person actually need to be seen in the hospital or in the clinic, in this facility? And they said, well, a lot of this could be done at home. And so what we did is we built this home-based cardiac rehabilitation technologies kit, which involved digital technologies. It was actually a wearable. It reminded people to exercise, to do something called a 6-minute walk test, reminded them to take their medicines. But also, if you had any questions, you could push a button and somebody would get back to you. And so that bidirectional feedback, sending data to the clinicians so they were aware of what's going on, clinicians actually coming back and letting them answer the questions. That was something that this program was based off. And what happened? The completion rate for this program went from 40% to 80%. It doubled, which is extraordinary. And so what that meant is for every 7 to 17 patients that completed this program, we were saving 1 life. It was extraordinary. We had about 100 or so patients start in this pilot. So I'll call it a proof of concept. It expanded to a couple hundred, went to 1,200. And then ultimately it was reviewed by the entire administration. And it is now considered the first line option, in addition, as an alternative to in-person. And right now, over 35,000 people have benefited. The impact this has had, not only in terms of completing the rates, the readmission rates have gone from 11% to 1%. These results have been published in the New England Journal Catalyst. It represents one of the largest scale implementations that is successful, in which they took this great idea from concept, pilot, to now large scale production. And how did they do that? One, they proved that it worked in terms of demonstrating its value. They found ways to make it workflow compatible. And then within the KP system, people are incentivized to be able to then deliver on this. And I think it's really that last piece that's the only missing piece for this to be widespread adopted across the entire globe. If we could find ways to encourage people to be able to be more supportive of preventive care as opposed to reactive care, I think that would allow us to be able to start thinking about this. But the essential elements from a healthcare organization standpoint were take a great idea, incubate it, test it, get the workflows right, scale it to the next point, and then continue to scale it to the point where it is considered just as good at, if not better than, what you're currently doing, and then make it first line option.
So really what you would say to the skeptics out there that are predicting a sort of a mass extinction event, so to speak, in 2026 for a lot of these AI startups as they transition from this promise to proof, is essentially that real outcomes, right? Real clinical outcomes is really where people should focus, right? Is that what you believe separates? And financial.
Yeah, financial, because at this day and age, as I mentioned before, if it's just about improving the overall quality, unfortunately, that doesn't move the adoption needle as much as making things easier for people. And in this case, it made it easier for patients, but it also made it easier for clinicians so that they could actually focus on other things that were allowing them to be able to become much more effective. But then at the same time, the readmissions dropped. Readmissions has a huge implication in terms of reimbursement and penalties, and finding ways that specifically we can improve upon that is both a quality issue as well as a cost and expense issue. So I feel like you have to have those type of pieces in there. Of course, the quality improvement, and it need to be clinical. The workflow has to be done right, but the key is also there has to be some economic element here. And in this case, the economic element is what it continues to drive a lot of interest in this. So it's the combination of all those.
I think it's tough though, because you've got this environment right now with hospitals operating in margins around 2.3%. 26 budgets are just being ruthlessly cut, right? And as you mentioned, people are focusing on soft ROI, like burnout and those types of things. But then really what seems to matter is more that hard ROI, which is the cash flow improvements, right? And then you've also emphasized, as you just said, that AI needs to make the process much more efficient, but it has to also focus on being inclusive, accessible, improving the outcomes. But are we setting ourselves up for a false choice there? Is there really still some genuine tension between AI for humanity versus AI for profitability that we're going to have to reckon with? What's your counsel to healthcare organizations out there on this hard trade-off?
Yeah. I think that a lot of organizations are looking at AI in too narrow a viewpoint. They look at AI as solving a specific problem, when in fact, AI may potentially open up opportunities for us to be able to address the bigger issues. So I'll give you two examples. One with ambient. With ambient, we look at ambient and say, oh my gosh, ambient has not been shown definitively to increase revenues. That wasn't the purpose of ambient. Ambient was to decrease clinician burnout so that in the long term, we actually have clinicians so that we can take care of patients and be sustainable. But that's not the short-term metric that people are looking at. But what it also does is it converts that entire conversation into a digitized format so that we can run things like revenue cycle management AI on top of it, that we can run other areas to optimize reimbursement, to make sure the notes are written in such a way that actually revenue is going to be captured, and also that allows us potentially to create opportunities for real-time prior authorization. These are the types of opportunities that could only have been opened had we now digitized it through the ambient. So think of ambient as an opening for a whole series of challenge opportunities that we have not even explored. Revenue cycle being one of them, but there's numerous others. Another one, we oftentimes think of AI as replacing, an individual task, like we're making their life better or replacing their task. When in fact, maybe what we should be thinking about is AI being brought on the front end to change the whole dynamic of how the number of patients that we're seeing and who manages them. So let's use some of the things that we're seeing right now. AI can be applied on large populations to identify individuals that have certain conditions that they may never have known. We can find patients that have diabetic retinopathy by looking at the retinal images. We can identify patients that have depression, stress, and anxiety by looking at voice as a biometric. We can identify patients with heart failure by looking at their EKG and different things that normally we would have required an echo, but we're now using different signals. So these are things that could never have been envisioned before, but AI can do all of those things. The problem is we're finding so many patients that it overloads the system. And so because of that, what we're finding is that people are saying, no, hold back. We don't actually run a role of AI because we can't handle the existing load. Well, now what we're looking at is AI to risk stratify and bring the highest risk individuals to care and then manage the medium to low risk through other channels. And so what does that do? It expands the pie. It expands the funnel. And so by doing so, the proceduralists, the cardiologists that do procedures, the ophthalmologists that do procedures, actually by shuttling the high risk procedure oriented patients to them will likely get if we can remove some of the medium to low risk and not send them to those patients, those individuals, we can actually increase the level of complexity of their visits and the number of procedures, and ultimately they get paid more in a fee-for-service world. So it's a win-win, even in a fee-for-service world, by expanding the pie. Now, what you've also done is you've added more individuals on the primary care side, which could potentially be managed by other individuals through other processes, whether it be digital, virtual, or even through other advanced care practitioners, leveraging the fact that they're now using AI. So what we're finding is that AI can actually, in many ways, increase revenue by increasing the funnel and ultimately allowing us to be able to treat the sicker of the sick by finding them and bringing them to care earlier. And at the same time, it delivers better care. So there's so many opportunities for us to start thinking about how AI can be applied beyond simply looking at it from a task perspective.
I think your point there about being open to the opportunity, it's one thing to start a pilot with certain implied outcomes. And then, as you said, be flexible as the data comes in to be able to expand and see future opportunities. But also, I think the reality is that with AI, it's still very much an emerging field. And we're going to discover along the way, as we're building the plane, so to speak, and flying it at the same time, we're going to discover all these additional opportunities we can't even possibly begin to think about right now. But on that particular note, and candidly, I think we're running out of time. I'm getting a note from our producers here, but I could talk to you all day. I do have one more question, though. I'm going to sneak it in before we have to go. And it's on this notion of the future, right? So thinking about your vision for 2023, you're coming to our conference in Arizona. You're going to be speaking at the Net Health Next conference, and your theme is all about where health tech becomes human tech. This whole idea that obviously clinicians will get more face-to-face time with their patients. You've touched on the empathy piece. You've spoken about human connection. But when you look out to 2020 and you look at what does success look like, what would make you say, yes, we got AI in healthcare right, and it made us much more human, not less?
Again, I love that question because it incorporates all the things that we are talking about right now. I think what we need to think about are how is AI, data, and interoperability going to allow us to be able to, with safeguards, be able to increase access to care, reduce costs, improve quality and safety, and ultimately create new opportunities for jobs so that individuals and our society can continue to grow. That's the bar that we need to raise. We need to think about beyond going from it solves a task and removes people from those processes to it elevates the opportunities for all of us. And as long as it's done in a way that's safe, inclusive, and ultimately one that's going to be cost efficient, it allows us to be able to deliver better care for all.
That's terrific. Thank you so much, Dr. David Rhew. It has been such a pleasure and such an honor speaking with you today. I cannot wait to see you in person in April at our conference. Thank you again for your time today.
It's been my pleasure. Thank you, Francesca.
What a great episode today. So today we covered 3 real key points. First, AI works best when it's an invisible partner, something that's built right into the workflows that clinicians can already use and actually gives them some time back to feel much more human. Secondly, we discussed that trust and good governance are not optional. Programs like Train show that responsible deployment matters, even if clinicians and patients are going to rely on AI. And finally, the real impact of AI goes well beyond efficiency and cost savings. It's giving clinicians more face-to-face time, helping them make better decisions, and improving the overall experience for both patients and providers, and driving to better outcomes. Thanks again for joining us, Dr. Rhew, and thank you to all of our listeners. If you're tuning in from Spotify or YouTube, we'd love to hear your thoughts on this episode in the comments below. And once again, I'm Francesca Vereb, Head of Marketing at NetHealth, and I'll see you next time.